So I am talking today about alcohol use disorder, and the goal of this is to be a brief overview. It's nothing, it's kind of the 30,000-foot view of alcohol use disorder, what it is, how do we diagnose it, and then briefly how do we treat it. More in-depth questions as far as acute management are a little bit outside the scope, but feel free to ask questions because it is kind of a brief overview. I have no disclosures to make. This slide's here because A, I can never resist an Eddie Murphy meme, and B, because it is a not so subtle reminder that when we are dealing with substance use disorder, not always, but almost always, we're also dealing with mental health conditions, and there tends to be a lot of trauma that goes along with that. So when you are in the primary care setting and you are dealing with your patients who are not doing the things that you're asking them to do, and it's very frustrating, bear in mind that chances are they've got a lot of pain and a lot of trauma has led to that point in their life. So the impact of alcohol is significant. We all know this, and usually on one of these impact slides, people put, X billions of dollars are attributed to the impact of alcohol, which is fine if you're doing public health. I don't have much of a focus on public health, but as physicians and nurse practitioners and other people who are doing direct patient care, we should care when people are dying. And so that's why most of the impact that you'll see here is it's about fatalities in addition to trauma, right? So we have a lot of people die, and directly attributable deaths. That is things like someone was driving impaired and had a traffic fatality, which you can see roughly 25% of US fatalities do involve alcohol. So those are directly attributable. That's acute alcoholic hepatitis. The amount of deaths that are not directly attributable, but are alcohol involved is much higher. That is complications of cirrhosis. That is things like if someone has esophageal bleeding, right, as a sequelae of alcohol use and of cirrhosis. Those are things as well that are attributable to alcohol use. But that 95,000, that's just very clearly directly attributable. So the actual number is higher. People are much more likely to have a suicide attempt if they have frequent alcohol use. And I mean, 7 times you look at the, I guess the odds ratio on that, 1% is not a very high number when we're looking at it as a percentage, but when we're looking at it as people, it's 1% is too much, and 7% certainly is far too many people. And then in addition to the direct fatalities, alcohol is a factor in about 40% of US violent crimes. This is pretty old data. This is from, I believe it's 2008, 2009. I couldn't find a whole lot of newer data on that. But when we talk about something like intimate partner violence, that number goes way up. So when we're talking about whether someone who lives with the victim or an ex, right, someone who has recently broken up, we do know that that's a high risk time for domestic assault, and a vast majority of those involve alcohol. So when we talk about alcohol use disorder, a lot of times we've kind of done away with the use of, abuse and dependence. That was old terminology. Certainly, we still colloquially talk about people being dependent and abusing. In terms of actual terms, we've got a few here. Unhealthy alcohol use is kind of an umbrella term. It means any way that people use alcohol that can have negative consequences, right? So these next few terms kind of fall under that umbrella. So risky use is basically, they don't meet criteria for use disorder, but they're having risk of health consequences, right? So binge drinking is risky use, but not all risky use is binge drinking. So risky use can be someone who is operating heavy machinery, and they may have 3 or 4 beers right before they go to work and operate heavy machinery. Now that may not qualify them with an alcohol use disorder. It's not enough in one sitting to qualify for binge drinking, but certainly it's use that could have consequences. So that's the sort of things that we think of when we think about risky use. Binge drinking does have a standard definition: more than 4 drinks for women or 5 drinks for men within 2 hours. Now, the way that they came up with that is essentially, this is the amount that for a typical person would cause the blood alcohol concentration to go up to 0.08 within that time frame. A lot of times, if somebody says, okay, well, I had, 7 drinks over 4 hours, okay, time frame wise, that may not fit within binge drinking, but that's binge drinking. And so we don't get too caught up within, the actual definition of, well, it's got to be within 2 hours. So a lot of times we'll understand that to be within one session of drinking. Now, certainly, if somebody has a 6-pack over the course of an entire day, float in the river or something like that, maybe not. But typically, if we're more than 4 in a day for women or more than 5 in a day for men, that is heavy use. And then alcohol use disorder, this is the actual DSM-5 disorder. And what it is, it's use that leads to clinically significant impairment or distress. And if it weren't clinically significant, probably wouldn't be in the DSM. So this is just a nice little infographic on excessive alcohol use. And so if you look back to the slide before, I would put excessive, that's that unhealthy or risky use. So if someone is under 21 in the United States, that's risky use because it's not legal for them. It may be that they have 1 beer on the weekend once every month. That's risky use because they are not of age. If a pregnant woman is drinking any amount of alcohol, that's risky use. And then we see these weekly amounts for women. That's kind of the bottom right of that circle there. For women, it's 8 or more drinks in a week. For men, it's 15 or more drinks in a week. There is some data. It's not been enough data to kind of move the needle on what we consider safe drinking. But there is some data that shows about 7 drinks or more, or less, about 7 drinks or less for males from a cardiac risk standpoint is what seems to have the lowest risk of mortality. And so when you think about that, this what we call, quote, safe drinking level, really, if we're talking about safe levels from a cardiac standpoint, it's probably quite a bit less than that. But this is currently the accepted definition of what's a safe level. Here are the criteria for actual alcohol use disorder. Similar to the other use disorders, there are 11 of them. They're sort of grossly broken up into physical dependence. So if you look at the DSM, that middle column there, DSM-4, we had alcohol dependence. And a lot of that is on its physical dependence and also sort of the mental, emotional. So gave up important activities due to drinking. You'll see that's the 9th criteria down there. And it's things that we think about when you think about dependence and what that looks like in someone's life. Yes, we think about tolerance and withdrawal, certainly, but it's also, how much time are you spending looking for these things? Are you blowing through your savings buying it? Are you missing out on work and home activities? Have you stopped your hobbies? You're not doing things you like to do because you're drinking all the time. That's the dependence part. And then alcohol abuse was also a DSM criteria. And that's sort of that, is it causing you problems and you're still doing it? So when we think about use disorders broadly, including alcohol use disorder, what we typically will see is we see use despite consequences. We see the physical dependence, which is the tolerance and withdrawal. And then we also see loss of control. And so what they've done with DSM-5 is they've kind of rolled both of these diagnoses into one alcohol use disorder. And so that's what we are dealing with now with the DSM-5. So there are a lot of different screens out there. The one that I really like is this NIDA quick screen. Although, so it checks for other substance use disorders as well, and then you can follow that up with secondary screening. But this is one that in Johnson City, in our family medicine, this is the question that patients are getting when we're doing our SBIRT. So this is the SBIRT screening, brief intervention, and then referral for treatment. This is the S on that, the screening. This is the one question that they get. In the past year, how often have you used the following? And then this is the question regarding alcohol. And if you think back to what we've talked about with risky use and hazardous use, this will catch binge drinking, but it may not necessarily catch a lot of other things. And so we always have to kind of have our antenna up for other things that maybe can go along with alcohol use disorder. But a lot of them are physical symptoms. We see things like hypertension. We sometimes will see a transaminitis when we're checking their labs. The AST, ALT are up. Again, typically that ratio, that AST to ALT is going to be higher than 2 to 1 when it's alcohol related. But this is a good quick screen that is going to catch a lot of the binge drinking behavior, but a lot of it is going to miss out. And so I think that's really important because we do use screeners, but also clinically, we just always have to be having these conversations. We always have to ask the questions that, whether it's about use disorders or anything else that maybe is a little bit more sensitive, we always just have to have kind of have your eyes open for it, because this is not going to catch all of the use disorders with this one question. Audit is it's a secondary tool. So this is the one that we use here in our clinic. If people answer yes to the one question screener, and it's 10 questions. Each one of them is 0 to 4, and they are questions like, has anybody, do your family members feel like you need to drink less? Are you having consequences? Are you using it despite risk? So some of it is overlap with the use disorders criteria, but not all of them. And then, so it's a maximum score of 40. And then these are here, sort of your different stratification of risk. There are a lot of other secondary screeners. So NIDA has one that's pretty good, but it's very in-depth. So on this NIDA quick screen, this is the only question about alcohol, but there are other questions. So there's a question: in the past year, have you ever used an illicit substance, or have you used a prescription substance other than how it was written? And so there's another tool that looks at all of those. The audit is alcohol specific. The NM is in neuromuscular, although that's not what it's named after. But the NM Assist is a tool that NIDA has that is for all of the various substances. But if you do have one that's alcohol specific, the audit is a pretty good tool to use. There's the CRAFT as well, that's spelled with 2 F's. But a lot, I think the CRAFT is proprietary. Mm-hmm. So you have to pay for that one. Forget that, use the audit. But the NM Assist is also a good tool if you have more than one substance in play. So if we have identified someone who has an alcohol use disorder, the next question is kind of, okay, what do we do? Now, ASAM, which is the American Society of Addiction Medicine, they have these different dimensions because as we talked about at the beginning, when we're dealing with a use disorder, we are almost never dealing with just a use disorder, right? There are systems in place in that person's life. There are other things going on that are going to affect their recovery, and it's going to affect their use. And so the 6 dimensions that ASAM uses sort of take that into effect. And there is a, I'm going to, let's see. Well, here we go. I'm gonna show y'all this. How do I get this part to go away? Do you know?
Can you pull it? Will it move? Can you pull it
Will
up?
it move? I don't know.
Drag your browser down.
Is that just the browser?
To the, oh, yeah, this makes me feel so old. I don't know how to use my computer. No, that's still okay. Anyway, I'm not going to share that one because I can't figure out how. But oh, there it is. Okay. No, it's not there. Anyway, ASAM has they just put it out. It's been about 6 weeks ago, probably. They have a good guide. It's about 25, 30 pages long. They put out in conjunction with UCLA. That's essentially a really, really in-depth intake tool. So it's about 25 or 30 pages worth of questions that goes over all of these various dimensions and the questions that you can ask about the different dimensions of care and what's going on with people. And it's a pretty good tool that if you Google ASAM, what is it? 6 dimensions questionnaire or something like that, you should be able to find it. And it's a free download, pretty helpful. So when we're talking about alcohol use disorder and what level of care someone needs, this is just very brief overview. You look across the continuum here, and usually by the time we are seeing someone, we've missed the ball on this prevention and early intervention. That's where public health efforts come in, education, being in the school system, right? But well, another plug here is a lot of what we're doing is prevention and early intervention for the next generation. But for our patients, we miss them, right? They're not coming in for prevention. They're coming in because there's already an issue. So this is where most of us hang out, is at the outpatient. Some of us here are residential and inpatient. So this is just the continuum of care. Now, if you want to do a 30-page intake with somebody and you go over all the dimensions and you score them and you go, oh, they qualify for a 3.3. Most of us are not doing that. And what happens a lot of times is you talk with someone and they go, okay, well, I'm drinking a fifth of vodka every day, might have a couple beers on top of that, and I'm done, I want to stop. And you go, well, we don't want you to die. And if you just stop now and we don't do anything else for you, you might die from that level of alcohol. You should probably go to an inpatient setting. And they say, no, I got a job, I don't have time for that. And so realistically, what we're usually doing is anytime somebody qualifies for a level of care and they're willing to go, you try to get them the highest level of care that you can. Most people are not willing to do that. And so we end up kind of trying to manage some of these level 2 people in the outpatient setting, and even occasionally some people who really should be inpatient. So what we do is we will say, okay, if you are not willing to go to an inpatient setting, we'll do the best we can with your withdrawal here. So here's just kind of a timeline of what you can expect. And they're varied. Seizures, it says 24 to 48 hours. They're reported seizures as early as 5-6 hours after the last drink. So this is just a very broad. You'll start to have some of the minor symptoms with the anxiety, that sort of thing, pretty early on, 6 to 12 hours. The hallucinations, can start earlier. And a lot of times we associate the hallucinations with DT, but they are not necessarily one and the same. So people can get, particularly the tactile hallucinations pretty early. Seizures can come after that. And then DT can come after the acute withdrawal. So what we do for acute withdrawal, mild to moderate can be treated in the outpatient setting. And as previously noted, sometimes we're managing more than mild to moderate in the outpatient setting, but ideally this is what we're managing in the outpatient setting. There are just a handful of risk factors here, right? Age greater than 40, renal issues, withdrawal despite high ethanol level. You know, people say, yeah, I just had a shotgun 3 beers and then walked in the door and they're withdrawing. It's probably going to get worse from there. And so for moderate to severe withdrawal, benzos are the gold standard. And these are not all of the risk factors. There is certainly a degree of clinical judgment to make there in terms of if someone's withdrawal is going to get worse. But we'll use Librium or chlordiazepoxide there. That's our kind of go-to for PO. A lot of times we also, here in our clinic, we do use diazepam PO as well in the outpatient setting. Lorazepam is preferred in severe liver disease because it does not have active metabolites, which the other two do. But that's our go-to. And there's like a fancy formula that you can use to figure out dosing of, you know, how much alcohol intake they've got and what their dose of benzos are going to be. That it's not a great science. It can give you a rough starting point. In general, for every 1 standard drink, you can ballpark that they'll need about 5 milligrams of Valium per standard drink, 25 milligrams of the Librium, or 2 milligrams of the Ativan, lorazepam. But that's just the ballpark. So it is typically, it's patient-centered, it's symptom-triggered. And so symptom-triggered is what we're used to doing, say, in the hospital. That's where we use our CWA scoring. Front-loaded is essentially if a 70-year-old who's got stage 4 CKD and heart failure and is drinking half a gallon of whiskey a day, if they come in and their last drink was 2 hours ago and they're already withdrawing, front-loaded is essentially you sedate them on the front end just to avoid issues down the road. Typically in the hospital setting, we're using symptom-triggered, and you can also do scheduled dose, and this is what we tend to do more in the outpatient setting, or we'll sometimes do a combination of scheduled dose with symptom-triggered management. And that scheduled dose, that's what we'll see sometimes. If we're doing like a detox protocol, we'll do Valium 5 milligrams 4 times a day for a day, and then 3 times a day, 2 times a day, and we'll taper them off that way. That's not a great slide. This is the CWA scale, and you can see the score goes very high, right? So the maximum score on this is 67. Anything above 20 is severe withdrawal. And if you just look about some of the scale here, it's not too difficult to get into mild to moderate withdrawal, even if we're going with only the subjective, right? Anxiety, some of the agitation can be a little bit subjective, but particularly the anxiety, you go, oh, how's it going? And they go, oh, I'm freaking out. Well, it's maybe a 5, maybe a 6. It's hard to say, but that's half of your, if you're scoring a 12, that's half of it in one question. And so the scores can go pretty high there when you're seeing acute withdrawal. The other thing to note, it's not just benzos. People who are going through acute withdrawal, they need a lot of other support. They need adequate hydration, typically with crystalloid fluids. You can give them some D5 and thiamine because we do not want them to have Wernicke's encephalopathy. And then we need to pretty aggressively replete their electrolyte abnormalities. They're very likely to have electrolyte abnormalities, bearing in mind that if you're getting a CMP looking at all their electrolytes, you're not actually looking at all their electrolytes. You need a magnesium too. So add on a mag when you're doing it. Some of the anticonvulsants, these three that I've listed here are some of the more common ones. We use those in the acute setting sometimes, but only as adjunct, only when it's mild. When we are dealing with anything that is moderate to severe or anything you suspect will be moderate to severe, benzos are still the first line. And then once we get past that acute setting, we have 3 FDA approved medications for alcohol use disorder. They are here. Naltrexone is kind of the go-to in our population. That is a no-go for a lot of our patients because, as noted, it is an opioid receptor antagonist, and we cannot use that in patients who are currently using buprenorphine, which is, of course, one of our first-line medications for opioid use disorder. So naltrexone, acamprosate, is a good medication that really the biggest or the most common issue with it is people usually don't take it as it's prescribed. It's 2 pills 3 times a day. It's a lot of pills. But the benefit of all these medications, which is a little bit different than say buprenorphine, methadone, the medications we have for opioid use disorder, is if you miss a dose of it, there's no withdrawal symptom, you're not going to get sick. Disulfiram, you will get sick, but only if you do take the medication. So it blocks aldehyde dehydrogenase, and so the liver cannot metabolize alcohol. And so people who drink while they're taking the disulfiram will get very ill. They have a lot of vomiting. So that can be a good motivator for people who are already abstinent. And we will use this sometimes. This isn't necessarily one that has to be used daily. It can be good for if someone has a high-risk event coming up, there's some sort of anniversary or party, or it's the Super Bowl or whatever. People can take the disulfiram in the days leading up to that to help prevent use. So these are our 3 that we have. And all of them are, as far as medications go, relatively safe. We do keep an eye on out for transaminitis with the naltrexone, and we would like to get a baseline renal function in acamprosate. And then with the disulfiram, you have to really counsel patients well about, like, watch out for your mouthwash, watch out for your perfumes, watch out for anything that might have alcohol in it, because they can have some nausea and vomiting with exposure to those as well. As always with use disorders, all those things we talked about, the medicine is the easy part. So the key non-medical management that always needs to be wrapped around when we're talking about a use disorder. Any kind of evidence-based behavioral interventions. We use CBT, contingency management, has some evidence in alcohol use disorder. Mutual support groups are a mainstay of alcohol use disorders. Motivational interviewing, patient education. We always have to address the system around the patient. We need to make sure that their health is taken care of. We need to make sure their relationships are taken care of. And that's really where the hard work of recovery comes in. And that's